anybody has any questions, please put your questions in the chat. We will be checking the chat regularly and also Emily will be responding to your questions. Thank you.
Yes, well, thank you so much, everyone, for having me. I'm excited to be here. As you heard, the majority of my work has been with children, primarily elementary and some middle school students with selective mutism. And it sounds like many, if not all of you, are working with adults at this point. So I will say some of the information in my presentation is geared more towards children, and that's really where the bulk of the work with selective mutism has been done, is with children and teens. We're just now starting to get into some more research and doing some more long-term studies and looking at what this looks like in adulthood, how adults are impacted by it, what children who were diagnosed with selective mutism, what their adult lives are looking like and things like that. So that research is very new and kind of still being conducted. But I'm hopeful that a lot of the kind of basic tenets of treatment that I talk about here, you can apply to your settings if you encounter individuals in your different contexts that have selective mutism. But yes, feel free to stop me with questions. This is one of my favorite things to talk about, so I tend to get excited about it, but certainly slow me down if you have questions, or you can put them in the chat. I will also say I put a lot of information into this presentation, and I'm happy to send it to you afterwards if that would be helpful. I'm one of those people who likes to kind of put everything in there so you have it as a resource, so that, if down the road you encounter someone with selective mutism and you're like, oh, I remember I went to that talk, but I don't remember the specifics, you can kind of go back and use it as a reference. So I'm happy to send this out and share it if that would be helpful. So one of the primary things I like to talk about with people is that anxiety and fear is something that everybody has. Everyone has a fear response, and that's not bad. So we need to have a fear response in order to keep us healthy, keep us safe, keep us away from things that are dangerous, and lead us toward things that are healthy and fruitful. But what that can look like varies from person to person. So generally we characterize fear responses into either a fight, a flight, or a freeze response. So a fight response might be a child who becomes very aggressive when they're anxious. They might become defiant. They might become verbally aggressive. They might be yelling things or become very escalated. A flight would be someone who tries to escape the situation. So that might be your children who get very overwhelmed and get very anxious, and they try to leave the room, they try to leave the situation, they might kind of elope or run from the area. Those individuals are very focused on just escaping whatever that anxiety provoking stimulus is. And then there's those of us who freeze. So those are people who are in an anxious situation and you just feel like, your brain kind of, goes clear. You're not really sure what to say. You're not really sure what to do. You just feel very frozen. All of these are common in people with anxiety, particularly anxiety disorders like selective mutism. I will say the freeze response is most often what we see. So that can look like individuals just looking like they can't participate in whatever's going on. So they might, get up in front of a room full of people and just completely freeze and not be able to move, not be able to communicate non-verbally or verbally in some of its extreme forms. So we do see kind of all variations of this, but the freeze is the most often one. So when these fear responses become overreactive and they occur at inappropriate times, that's when we start to look at, is this an anxiety disorder that's happening? And so one type of anxiety disorder is selective mutism. It is an anxiety disorder that results in the inability to speak in certain environments, despite being able to speak appropriately in other environments. So for most of the students I work with, they can speak appropriately at home, they can talk to at least one person in their family, but they shut down when they're at school, they shut down when they're in the community or extracurricular activities and things like that. With adults, we can see the same thing at the workplace. So they might be comfortable at home or with a spouse or with parents or with siblings, but in the workplace, they really struggle to engage verbally. Certainly those of you that are working with higher education might see this in your classrooms if you have an adult with selective mutism. We typically see this first manifest during the preschool or early school years when kids are first exposed to an environment outside of the home, but certainly it can manifest a little bit later too, but it's most often first seen in early childhood. This is the diagnostic criteria from the DSM. I won't go through all of this, but the main points are that they can talk in one environment, but not in at least one other, that it lasts for at least a month, which is important, especially when we're talking about people who are English language learners, because we certainly know when learning a second language or a third language, it's typical to have a silent period, right? So it's typical to have a period of time where you're taking in that new language, but you're not yet using it expressively. And so that's a piece that we have to be really careful with when we're looking at someone who is multilingual and potentially has selective mutism, is really the timing. So how long is this lasting? And that's kind of one of the components we use to diagnose, is this a typical, trajectory of someone learning a new language, and this is a typical silent period that they'll move through, or is this an anxiety disorder and we need to provide treatment and intervene so that they don't get stuck here? So with SM, we look for it to last at least a month, and that it's not due to just a lack of knowledge about the language. So again, we want to make sure that we're not diagnosing kids who are going through a typical English learning process as having selective mutism if they don't. We really want to be careful about, who we're assigning this diagnosis to. This might be some ways that you would see SM manifest, especially in the classroom. You might have people who are hesitant to participate, whether verbally or non-verbally, lack of eye contact, difficulty asking for help, difficulty letting you know that they're lost or that they didn't understand a direction. Asking and answering questions is very difficult. Like I said, you might see that freeze response where you're expecting them to participate and suddenly they just kind of shut down and get kind of immobilized. And difficulty sharing opinions or preferences. That can be something that's particularly hard for these kids because sharing an opinion is a very personal thing. And it's something that people often feel like they're going to be judged for. So it's additionally anxiety provoking in addition to just kind of speaking. The causes of SM, I will say in a nutshell, are multifactorial, and we don't know exactly what causes it. So there's a little bit of both. We do know that there's a lot of components that contribute to it. There is evidence that there's a genetic factor. So often there's a history of anxiety disorders, sometimes selective mutism itself, sometimes other anxiety disorders in the family. We often see this with individuals who have temperaments that lend themselves more to selective mutism. So people who are already shy or inhibited or very reserved. We definitely see an environmental impact in terms of how the people around the person might be reinforcing their lack of speech or not reinforcing it. Also, we often see with children that when parents are socially anxious or avoid certain situations, children watch that and they learn, oh, I shouldn't go to this situation. It's going to make me anxious. It's bad to do this. They learn from their parents' behavior. So if we have parents who are anxious and are avoiding certain situations, they can sometimes pass that on to their kids just by observing them. And then certainly within children themselves, having other anxiety disorders, having social anxiety disorder, having other specific phobias makes them more likely to have selective mutism. Just catching up in the chat here. So I see the question, does selective mutism impact learners' capacity to communicate through writing also, and are they able to read? Great questions. Some of the research shows that children have lower reading skills in terms of oral reading fluency. We don't know yet if that is, that they're more likely to have learning disabilities and reading things in general, or if it's due to a lack of practicing reading out loud. So you can imagine if you have a child who's not talking at school, they're not reading aloud at school, they're not getting that practice with oral reading. And so their ability to read out loud might be compromised because they haven't practiced as much as your typical child has. So we're not quite sure what the causal effect is there, but there are some children that have lower reading skills. In terms of writing, it can certainly impact their writing. It's usually seen more in personal writing and narratives and anything where they need to share an opinion. So they're usually better able to do factual writing. So talking about, facts from something, doing a research paper maybe, but if you're asking them to write their opinion about something, to write a persuasive essay about something, to share a preference about something, that can be more anxiety provoking and you might see more hesitation there. That being said, often we see kids first communicate through writing before they communicate verbally. So that might be a step they take towards speaking. So it might be kind of that avenue that they use. In terms of biological factors, what I think is interesting here is that we do have some research that shows there are differences in the brains of kids that have selective mutism. So brains are actually responding differently to stimuli, and that can be causing them to have these overly anxious responses to things. So there's no evidence that it correlates with abuse or neglect or trauma. That's a myth that's out there that it's caused by trauma. Trauma can cause mutism, but that's separate from selective mutism, and that's usually related more to the traumatic event, not to kind of general settings like selective mutism is. But what we see is that the amygdala, which is the part of the brain that's responsible for fear responses, is more likely to react in kids with selective mutism. It takes less to cause a fear response in them. So something that might not trigger a fear response in typical children will trigger it in these children. So it's more reactive, and it takes longer to calm back down after it's been triggered. So you can imagine these kids, they're already kind of at a higher level of anxiety. It takes less to kind of trigger them over the top. It takes longer for them to calm down. So you can see why so many more things would be more triggering for them than kind of your typical child, who is a little bit more resilient and not so sensitive to all of those different stimuli. This is a slide that I think is important, especially when working with children or when you have parents or other adults in the situation, because it's important for those around the individual to understand how their actions can impact kind of the reinforcement of the mutism. So the example I like to use is if we start up here at the top, if you as a parent and your child with selective mutism are in the grocery store and you run into one of your coworkers, and the coworker says to the child, oh, it's so good to see you. I haven't seen you since you were a baby. How old are you now? The child's prompted to talk. Now, the child probably isn't familiar with this person. They're probably going to experience some level of distress and inhibition. So they might not make eye contact. They might look at the floor, or hide behind the parent, or even try to walk away from the situation or turn their body away. So they're experiencing a fearful response. They're very anxious and distressed. The people in the environment observe that distress. So both the parent and the coworker see this child is upset and anxious and uncomfortable. And like any adult, they have an empathic response and want to help the child and help them feel better. So either the parent might jump in and say, oh, she just turned 7 last week. She just had a birthday. How are your kids doing? Kind of answer for the child. Or the coworker might kind of cover and be like, well, you've just gotten so big, like it's so good to see you, and kind of continue with the conversation. What happens in that instance is everyone feels relief. So the child feels relief because they didn't have to talk, which was what they were anxious about. The parents and the adults feel relief because the child is no longer distressed and they've kind of taken this anxious situation and gotten rid of it, and everyone kind of feels better. But the problem is that what's occurred is what we call negative reinforcement. So the child has just learned, whether consciously or subconsciously, if I avoid talking situations, if I hide behind mom, if I look at the floor, if I walk away, if I turn my body away, someone else will jump in and talk for me and I don't have to talk. So it creates this loop of I'm in an anxious situation, I avoid the behavior, someone else will take care of it for me. And over time, that loop gets reinforced and reinforced and reinforced, often unknowingly by parents, because again, they're just trying to help their child feel better and kind of resolve a problematic situation. And so, you can imagine after years of this, these children have a really strong behavioral loop in their brain of avoiding these situations. And so it takes a lot of intensive treatment and intentional treatment to really negate that loop and change it to what we call a bravery loop. So, you could certainly imagine this happening with adults. If they're in situations where they're, prompted to respond and a friend or a coworker jumps in and responds for them, again, trying to be helpful, it still reinforces that avoidance cycle of if I just wait it out, if I just don't say anything, if I just look down and kind of don't engage, someone else will do it for me. And so that becomes very ingrained over time. So we really want to teach parents and teachers about this cycle and kind of help them understand how to change their behavior. So they're not reinforcing avoidance anymore, but instead they're reinforcing bravery and communication and verbalizations. Okay. I'm going to just briefly say for this slide, what I like to teach parents and teachers is we don't want to rescue our kids. So in that example, when the parent answered for the child, we call that rescuing. That's jumping in and doing something for the child instead of helping them do it for themselves. And the reason we don't want to do that is when we rescue a child, what they experience is their anxiety climbs and climbs and climbs, and it peaks. And then a parent jumps in and rescues them, and suddenly their anxiety drops really low. What they remember from that encounter is the height of the anxiety. They remember this peak they remember someone talked to me and I got so anxious and it felt awful and I never want to do that again. So that's what stays ingrained. By contrast, we want to teach kids to ride out their anxiety, or adults. So we want to help teach our individuals with SM that when you're anxious, and you do something over and over and over again, it doesn't feel as bad once you keep doing it. So it will get easier and easier as you keep doing it. So we kind of show parents, the first time the child's prompted to do something, they're still going to have this really anxious response. By the fourth time they're prompted to do it, it won't be quite so anxiety provoking. And by the eighth time they do it, it's very minor compared to what it was initially. So, you can probably relate to that in your own lives. Probably the first time you had to teach on Zoom, you were a little bit anxious about it. And then you did it over and over and over. And now we're all pros at it and it doesn't make us anxious anymore. And again, when we teach kids to ride out anxiety, they get to experience the whole process, which includes the calming down process. So it's not just their anxiety gets really high and then someone saves them and they're fine. Their anxiety gets high, but then they experience getting through the anxious event and they feel their body start to calm down. And so it teaches kids that even when you feel anxious, it's not going to last. It's going to stop. It's going to get better. You will calm down again. You will feel better again. So they get to experience this whole cycle and they start to remember the calm at the end rather than just the anxiety at the peak. Just some statistics right now, SM affects about 1 in 140 children. It's more often diagnosed in girls than boys at this point. But again, we have some questions as to whether that has to do with having greater social demands on many of our girls than we do with boys. But that's currently what the statistics are. The reason that I felt it was really important to talk to this group about selective mutism is that our research is showing that children who are bilingual and children who are immigrants from other countries are significantly more likely to have selective mutism than monolingual children or non-immigrant children. So the research shows anywhere from 3 times to 13 times higher in immigrant children, and also similarly much higher in children who are bilingual. And so we don't quite know why yet. Certainly we know there's a lot of benefits to being bilingual or multilingual and speaking multiple languages. So, we never want families to think that, that's a cause of it or a problem or a bad thing. But we do know that this population is at a much higher risk of having this diagnosis, and we see it more often in this population. So I think it's something for those of you who are either working with English language learners or teaching people who work with English language learners, something good to be aware of, that as we get more awareness of this topic and as we get better at diagnosing it, we may be seeing it more and more in our classrooms and with our students and our adults.
Emily, we have a few questions in the chat, if I may.
Yes, sure.
Okay, Max says, oftentimes when people are aware of the patterns of communication in specific contexts, they become more communicative in such contexts. When they do not know how language typically unfolds in a given context, they remain silent. Should we take them as selective mutism cases, or is it something else?
I would say in that context, if you're referring to people who are still learning the language and maybe learning a new culture and learning those new contexts and scripts, I would not be quick to call them selective mutism, because again, we want to make sure it's not just lack of comfort or lack of knowledge with the new language. And I think we're going to get to that in a couple slides here, but we want to look at, is this occurring in the primary and the comfortable language, or is this just occurring in the new language? So I would say if this is just happening in situations where the new language like English is expected and they're not completely comfortable with English or with the culture that they're in or the scripts associated with English, that would not be selective mutism. But if it's happening across languages, if it's happening in both, their native language as well as English, or their primary language as well as English, and it's more setting related rather than interaction related, like it's always happening at school, it's always happening at work, it's always happening out in the community or at church, that would be more of a case of selective mutism.
Great, thank you. We have another question from Francie. She says, could you elaborate on the difference between trauma-induced mutism and selective mutism, please?
Yeah, so really the main difference that we see there is selective mutism, we tend to see manifest in early childhood years. So we tend to first see it in like ages 3 to 5-year-olds. And often parents will say they've seen signs of it even younger, even as babies and toddlers. Sometimes they've seen kind of inhibition and shy temperaments and things like that. So it tends to be a very early on diagnosis. Trauma-induced mutism tends to occur right after the trauma happens, so it can happen at any age. It would be rare for selective mutism to start in later childhood or adolescence or even as an adult. That would be highly rare and atypical. So if this is happening, in those later years and it's happening after a trauma, that would suggest it's more the trauma-related mutism. Also, trauma-related mutism tends to be specific to triggers related to the trauma. So the child might become mute whenever they're around people who are associated with the trauma, or whenever they're in an environment that was associated with the trauma. So maybe a child who goes through, a very significant car accident, when they're riding in the car, they might have trouble communicating, or when they're around the place where the accident happened, they might have trouble communicating. Or if there were police and firefighters involved, they might become mute in situations where they see those people out in public. So specific triggers that are associated with the trauma trigger the mutism, versus, again, kind of that larger setting or environmental component of just every time I'm at school, I can't talk, or every time I'm out in the community, I can't talk.
Great. We have one more question. Why do we always feel we need to rescue people when they struggle for language? It is such a gift to give people time to find the exact words they want to choose. That's really.
I think that's a great
Yeah.
question. And I
Yeah.
think as a society, we're very uncomfortable with uncomfortability. We don't like to see other people be uncomfortable. We don't like to feel uncomfortable. We like to kind of fix things and make it okay and make everyone feel better and know that everyone's happy and know that no one's struggling. And I think a lot of that comes from empathy, right? Like I said, I think in most of these cases, people aren't trying to jump in. They're not trying to cut people off. They're not trying to, be controlling. They're just trying to help. And so the way that they know to help is, this person isn't able to answer, I'll answer for them because I'm pretty sure I know what to say. Or they're too anxious, I want them to feel better, I'll solve this problem for them so they don't have to feel anxious. So it comes from a good place, but you're right. I think there's a lot to be gained from giving time, giving space. And we'll talk about that, waiting 5 to 10 seconds after you answer a question, which sounds really easy to do, but when you're in an interaction with someone who's, struggling to speak, and, you're asking them a question and in your head, you're counting a 10-second wait time, that feels like a really long time because we're not accustomed to waiting that long for a response. We're accustomed to asking a question and expecting a response immediately. So I think, that's a function of some of our culture and some of our society for sure. And I would be interested to see if there's other cultural components to that, and maybe other cultures that aren't so in need of immediate gratification and immediately solving problems and things like that. But great question.
Great, thank you so much. One more question from Joanna. She says, I'm thinking about S-Life, I think that's how you say it, students who are transnational. Would they have a tendency of having selective mutism because of the changes in their settings and the stresses involved in that?
I'm not familiar with the term S-Life students. Joanna, could you just qualify or kind of clarify what you mean by that?
So students called, well, there's SIFE and SLIFE, but it's students with limited interrupted formal student, I'll say it slowly, students with limited interrupted formal education.
Oh,
so
okay.
in ESL teachers, we can have students who say they spend 6 months on the East Coast and then 6 months they travel back to Mexico and they work for 6 months there and they come back and forth. And that's like transnational, for example. Or there could be other students who are, when they're young, they didn't have formal education. And so they're like missing a bunch of information that we would normally would expect our students to have. So I'm just thinking about the different stresses involved that you were talking about and how, perhaps it's so interesting what you were saying about ESL students, that there's a higher tendency for them to have SM. I normally think of like teenagers with, selective mutism, like they don't want to speak for something, going through a phase. But anyway, I was just thinking about the stresses and strains of different aspects of students and in terms of movements, in terms of not being not knowing the information, the cultural information, the content that the teachers would expect of them because they're not in class and they're in another country for a chunk of time. So that's what I was thinking about.
Definitely. I would say in those cases, it certainly could be, a red flag or an at-risk factor. Certainly, we know these children are more anxious by nature, so they have underlying anxiety. So I would say if you have a child with an underlying anxiety disorder who's then put in those situations where there's a lot of transition and a lot of adjustment and a lot of upheaval, that certainly could make them more likely to have selective mutism. I wouldn't say that that alone could cause it, again, unless you have that underlying anxiety there as kind of a piece of it. But certainly could be kind of a risk factor associated. And I would want to be really careful in that instance that we're not jumping to an SM diagnosis when, like you said, they just haven't been exposed long enough. They just haven't had enough time in any one place to become comfortable with the scripts and the context and the expectations and things like that. So I would say that would be a case where you'd want to work really closely with probably a psychologist and an ESL teacher and maybe a social worker and kind of look at all of those different factors.
Thank you.
That's great. Thanks, Emily. These are the questions we have in the chat so far.
Great. So some of the cultural factors that have been explored in this new paper by Jamie Furr and some others is looking at kind of how different cultures might view selective mutism. And so some of the interesting factors are kind of, you know, some cultures have much higher expectations for compliance and obedience from kids. And so they see, you know, when asking a child a question and that child doesn't answer, they see that as a compliance issue or a defiance issue. And so they're more likely to look at this as my child's not behaving, they're being disrespectful, they're not, you know, answering questions, they're not respecting authority, and not recognize that this is an anxiety disorder at its root that needs, you know, treatment rather than a behavior disorder that the child's choosing to engage in. By contrast, there's other cultures that are much more accepting of shyness, individual choices, you know, to not speak or to be quieter. And so they may be slower to recognize that there is a disorder here that needs treatment because they're more accepting of, you know, well, that person's just really shy. That's just how they are. They just don't speak. And not recognize how limiting that can be either now or potentially in the future for that individual. Again, and certainly there are certain beliefs where parents see their child's behavior as a reflection of their parenting skills. So that can be a factor too. If a parent's feeling like my child's not talking to their teacher, that's so embarrassing, they're going to think I'm a bad parent, you know, this reflects poorly on our family. There can be all those interesting dynamics that come into it too. So just recognizing that kind of this diagnosis can be very freeing for some families to recognize that this isn't something you caused, it's not due to your parenting, your child's not a bad kid, they're not making this decision, but also it can be very foreign to them and something that they may not have on their radar at all. So I think those are interesting factors to keep in mind with the very different cultures that I'm sure all of you work with. So this, I think, is a really important slide for your populations, is kind of distinguishing between what selective mutism is and what that typical silent period might look like. So typically for an onset of selective mutism, we see it happening around 3 to 5 years. The research I was reading says kind of the silent period for young children who are first getting exposed to English might last between the ages of 3 and 8. The duration for selective mutism is, like I said, at least a month beyond that first month of school, versus a silent period, which might be more 3 to 6 months. The languages that are impacted are really important to look at. So for selective mutism, we see it impacting all languages, including the primary language or the native language, versus a silent period would really just impact the new language that the child's learning. In settings, we see SM across multiple settings, regardless of what language is expected, versus with a silent period, we see that more just where the new language is expected. So you might be seeing it at school because that's where the child is expected to speak English, but when they're in situations where they can speak, you know, Spanish or Russian or Polish, they're perfectly comfortable and perfectly able to do that. And the big difference is the progression, right? So a child with SM rarely gets better without treatment. So children don't typically outgrow this. They don't typically just get better and better as they get older. They don't typically just, you know, flip a switch and grow out of it. They often almost always need some form of treatment, versus a child who's just developing a second language typically will move through that silent period and begin to start using language as they get more familiar with it, and they won't need, you know, formal treatment necessarily. So some things to keep in mind as we're kind of differentially diagnosing these pieces.
I'm going to have a question.
Yes.
Are we distinguishing between general anxiety disorder, GAD, and trauma, which is more situational when you diagnose selective mutism?
Yes, so I would say all three of those things are separate diagnoses. They're all separate in the DSM. So a large number of our children with selective mutism also have generalized anxiety disorder. There's a pretty significant overlap there. I think it might be in the range of like 70 to 80%. Also with social anxiety, that's another very common one for our kids with SM. But most of our children with SM do not have a history of trauma. Certainly there's always a little bit of overlap, but it's not caused by trauma. And so it's not, commonly seen in kids with SM. I'm just looking at this other question. Is the intervention the ESL teacher, the speech therapist, or a combination of professionals? Great question. It is whoever is trained in some form and whoever has the ability to work with the child on a regular basis. So it can really look different depending on the school or the situation. It could be you guys as the ESL teachers. It could be the speech therapist. It could be a social worker. It could be the school psychologist. It could be a paraprofessional in the classroom who just has the opportunity to interact with the child every day. But whoever it is, it's important to have that key worker who has some of these skills that we're going to, talk about, or maybe not talk about as we're running out of time, but have some of these skills that I'll kind of send to you guys so that they can work with the child on a regular basis and can just be a regular, consistent presence who's kind of keeping up with where the child is and kind of orchestrating different interactions to kind of help them talk in more situations to more people. So I'm going to skip this slide. This is just some different ways that anxiety can manifest, which you may be familiar with. These are many of the comorbidities we see with our children with selective mutism. Again, speech and language disorders is a big one. Anywhere from 35 to 75% of kids with selective mutism have additional speech and language issues separate from learning a new language. So again, these kids can really have a lot of different components going on. So just good things to be aware of. We kind of talked about there can be impacts on reading skills, there can be impacts on language skills. And so that is certainly a factor. And then we're starting to see these long-term impacts. Like I said, we're starting to look at how children with SM who didn't receive treatment are now becoming adults who have all of these different impacts, anxiety, depression, poor relationships, difficulty in work settings, things like that.
So we have a question, Emily, from Mac. Emily, could you please share a case you dealt with? It will be so interesting to hear about the case you dealt with.
Sure. So I have an interesting case right now. I have identical twins on my caseload at school. So they came to me in kindergarten. They're in 5th grade this year. They are somewhat bilingual. Mom speaks Russian fluently, and they speak some Russian with mom. Dad speaks English, so they mostly speak English with dad and at school. And they came in not talking to anyone outside of their two parents. So never talking to a neighbor, not talking to their grandparents who lived in a different state, not talking to any peers at daycare or at preschool. And so they qualified for speech therapy at my school, as well as some other things. And so what I've done is really work with them over the years to first get them comfortable with me and get them talking to me. And then to kind of fade in other people. So once they were able to talk to me, then we practiced them talking to me outside of their classroom. And then we practiced them talking to me in their classroom with nobody else around. And then we practiced having their teacher in there and them talking to me and then slowly talking to the teacher. And then we brought in 1 or 2 kids and had them practice talking to the teacher and 1 or 2 kids and slowly kind of integrated more and more kids. And so we've done that slowly, but very intentionally over the years, really scaffolding that process and working on, talking to the school nurse, talking to the secretary, talking to the library teacher, things like that. And actually one of the twins just yesterday was able to give a presentation in front of her class for the first time in her life. So she stood up in front of her entire class. She read her presentation. Her volume was a little low, but everyone could still hear her. And her class was so excited for her because a lot of these kids have been with her since kindergarten and have kind of known, she's the kid that doesn't talk much or she's very quiet. They were so excited. They all got up and gave her a standing ovation and clapped for her, which was just so cool. So I will say there's a lot of hope for these kids and these individuals, but it really does take some intentional treatment. Like I said, they don't generally grow out of it, but they can make really great progress and they can go on to lead really productive, social, very connected lives. But we just want to make sure that we're giving them the skills that they need to do that and the support they need to do that, rather than just kind of saying like, oh, she's really shy, she'll grow out of it. which if that's the big thing that you guys take with you tonight, I hope that's the big message, is that, you know, they can make tons of progress and they also sometimes need help in order to do that. So I know we're kind of low on time here. There's, you know, probably 50 more slides here for you to read, and I knew we wouldn't get through all of them. But just so you know what's in here, I have some information here about treatment strategies that we use. I would say this shaping is probably a good slide to take a look at. It talks about how you kind of make that transition from a child talking to maybe just an ESL teacher or just a speech therapist in the classroom to then being able to talk to someone else in a really step-by-step kind of fashion. So that's here for you to look at. There are some specific skills that we use here with children. Again, you could kind of adapt these to work with adults, for those of you working with adults. And we really make the distinction between using more descriptive language. So kind of having a warm-up period where you're just describing what the child's doing, you're making conversation, but you're not putting any expectation on them to talk. And then once they've kind of warmed up and become comfortable, then you start very intentionally asking questions. And we usually start with forced choice questions. So a question that has all of the options right there in the choice. So like, did you go home? Did you stay home this weekend, or did you go out and do something, rather than what did you do this weekend? So it gives them more concrete words to kind of latch onto and choose from, and then kind of moving on to open-ended questions. So those skills are in here for you to look at. There's videos here if you're interested to kind of see examples of clinicians using those skills. So those will be here because I know we didn't have time to go into that tonight. And then this is the fading in process that I talked about. So this would be how, if you've got the child verbal with one adult, you could kind of fade in a second adult and get them verbal in a very, you know, sequential step-by-step fashion. So again, you could certainly adapt this to different adults that you're working with. And then there's some ideas here of activities. Again, I know most of you aren't working with children, so these might not carry over as well. But different activities that you can work on at each level of complexity. So starting with just nonverbal, then making sounds, then moving up to word level things, then phrases and sentences, and eventually getting into questions and longer comments and things like that. And then finally, there's some specific tips here for kids who are ELLs and have selective mutism. So those are there for you to look at. If you're interested in these topics, I would highly recommend anything by any of these researchers and clinicians. These are great people to follow up with. And I also included some resources for you. So there is the toolkit for educators. So if you're working in a school-based setting or you're consulting with people who are working in a school-based setting, the Selective Mutism Association put together this toolkit, which is really helpful for teachers. There's some resources here about selective mutism, some websites that are really helpful to check out. And then certainly if you have any questions, like I said, I love to talk about this topic. I usually do like a 3 or 4 hour presentation on it. So to squeeze it all into like 40 minutes was tricky for me. But I'm happy to talk more if you have specific questions or you have specific cases, or you just want to follow up. Certainly feel free to reach out to me. And then the references are here again if you're interested in looking that up. So I see there's some new things in the chat. The expression fading in, yes. So yes, you could say phasing in as well. We tend to use the words fading in because we talk about, someone fades into the interaction and then the other person fades out of the interaction. But same concept as phasing in, if that's a term you're more comfortable with. Yeah, so thank you for all of your questions and for your engagement. Children that stammer, can they be regarded as selective mutism? So actually those are 2 separate diagnoses. Interestingly though, children who stammer or stutter are more likely to be anxious children and to have anxiety. And obviously children with selective mutism have underlying anxiety. So they both can stem from an anxious place, but it manifests 2 different ways. I will say I have a new student who just came to my school who I think is both. He seems to have characteristics of both stuttering and selective mutism, which is certainly, and he's also an ELL, of course, his family speaks Vietnamese. So he's got a lot of things going on that we kind of have to sift through and look at, what can the ESL teacher address? What is stuttering that I as the speech therapist will address? What is selective mutism, which I can also address, and kind of how we deal with all of those very different aspects. But I would say stuttering or stammering and selective mutism are 2 separate things. They can occur together, but they're separate.
Emily, we have a comment from Mac. He says, I teach adults with many attributes of children's language proficiency in second language. I'm not at all condescending to their journey. I am one of them. Um, uh, would you like to say more about this, Mac, in terms of language proficiency and working with adult learners, working on their language proficiency and competency?
Thank you, Helen. I knew nothing about this topic actually, and it's been really great learning about it. So I come to ESL Emily from applied linguistic background, and in my training, it was taught to me that learners perform better when they're aware of how language unfolds in particular context. So, and when they are not aware of, they become underconfident, they become more anxious. Let's take an example of making an oral presentation. So when students are unaware of this genre of oral presentation, how the language is organized and how language features differs in an oral presentation as compared to discussion, they naturally become more anxious. So my training was, especially for second language learners, when they come to a country where the culture is different and they're unaware of how language unfolds in particular context, they become underconfident, they become anxious. The same thing I come across with my adult students in my classes. I didn't know about it. So this is something very new for me. And many of my students remain very quiet.
Yeah, and I think that's something that, hopefully if you have a chance to kind of look through some of the suggestions and the strategies in here, these are strategies that probably are great to use with anyone who's learning English. A lot of overlap is the same. And, anyone who is quieter or more hesitant to communicate, even if they don't meet the diagnostic criteria as selective mutism, these strategies may still be helpful for helping them to feel more comfortable and less anxious and more able to speak. And the other thing I was thinking is one of the things we often do in treatment is scripting. So when we have kids who are practicing having conversations or even just asking a question, we'll write down exactly what they're going to say and we'll role play it. So oftentimes what I'll teach parents to do is how to practice in small steps before you do something. So if their goal for their child is to order a donut at Dunkin' Donuts, I'll have them role play that multiple times before they're actually in the interaction, so that, like you said, the child's very familiar with what's going to happen, what the person's going to say, how they're going to respond, so that by the time they get up there, they've already practiced it 5 or 6 times. So like that chart we looked at the beginning, hopefully their anxiety is a little bit lower because they've been through the interaction several times. But 2, they know what to expect. And so they're more prepared. They feel more confident. They feel more competent as communicators. So really teaching parents to say, okay, well, let's pretend I'm the person at Dunkin' Donuts. I'm going to say, hi, how are you? What are you going to say? You can say, good. Let's practice that. Hi, how are you? Good. And so you really go through that scripting of, over and over practicing those skills so that they're not anxiety provoking anymore. And then certainly you move away from that and eventually get to the point where kids are doing it spontaneously, but that can be a really helpful step in getting kids to that point.
I noticed in a situation with selective mutism, the person, even an adult with selective mutism, they might have a close person to them, like a close friend. And if they want to say something, of course, they can't say it. And then they would whisper to their close friend what they want to say. And that's how they communicate their thoughts. And then their friend either comments or give them feedback, or he would say, this is he would say, this is what he's trying to tell. This is what he's trying to say. So is that the only way that they might communicate when they have to speak, like whispering something to a close friend, or maybe in writing? Or are there other ways that they can communicate when they have to speak?
Yeah, so I would say those are definitely both strategies. We call that using a verbal intermediary. So a child might use a parent, or a child might use a friend that they're very comfortable with. An adult might use a friend or a coworker they're very comfortable with. And so we try to take what the child's able to do and then help shape that into something that's a little bit more functional. So for example, if the adult is talking to a coworker and they're whispering in the coworker's ear, we might then have the coworker take maybe one step away. And so the adult's, whispering it, but a little bit louder. And then maybe another step away, and now they're talking at a soft, audible volume. Meanwhile, the coworker can be doing reflecting. So, if I, as maybe the supervisor, ask the individual with SM a question, they can't answer me directly, but they whisper it to their coworker. The coworker can reflect and say, oh, they said they'd have it done on Monday. And then the next time, like you said, we have them take a step further apart. And eventually, starting to coach and say like, great job telling me, now go ahead and turn towards Emily and tell her the answer. So working on, first practice with the comfortable person, now practice turning and saying it to the new person and things like that. So really doing it, very step by step and very sequentially. But like I said, using what they can do and then shifting it and shaping it slowly but surely towards something that's more functional for them.
Right. Thank you so much. We have a comment from David. He says, I'm familiar with the Armenian and the Polish of Warsaw communities. I have seen this behavior in adults and simply accepted it. I thought of diagnosis as a child excites me. Yeah, okay, so diagnosing it as a child, he finds it interesting. Thank you. So what would change if the person were 35 or even 50? Oh, yeah, if they're older, can they like overcome this selective mutism anxiety? Can they be taught some strategies to overcome this even at a later age? Yeah, okay.
Yeah, I would say absolutely. I would say the biggest change would be you won't have a parent directing your treatment at that point, but rather you as the individual are really going to have to kind of take hold of that treatment and really be the motivating factor for yourself and be kind of leading that treatment, and directing that treatment. And so the Selective Mutism Association is really working to put together more resources for adults that have selective mutism, so that, because we're finding a lot of people, as awareness of this grows, a lot of people are going like, well, that sounds like me. Like I never talked to anybody as a child and everybody just thought I was shy and, it was just accepted and it wasn't a big deal. And, are now recognizing like, wow, this explains why I have so much trouble in these situations or that kind of thing. So certainly we want to spread the word and get people help. I would say the first step as an adult would be to seek out a psychologist who has training in cognitive behavioral therapy. A lot of the strategies that I share in the PowerPoint come directly from cognitive behavioral therapy, and that is the gold standard for working with selective mutism. So certainly a psychologist could help with that and with kind of any other underlying anxiety that may be at work, because, if you've gone 35 or 50 years of having significant anxiety, you probably need some coping skills to deal with that or some help dealing with that. So certainly a psychologist could help with that. But yes, certainly we know the brain continues to be malleable. We can always make new pathways and learn new things. So certainly you can always build those bravery loops and build those new skills. I think it would just really fall more to the individual to take ownership of that.
Right. So Joanna is thinking about our quiet students. She says this means that we need to be even more humanistic when caring in our approach to our quiet students. Yeah, I agree with that, because sometimes we don't know, like, why are they quiet? Is it language barrier? Is it something else? Right. So that's right. I agree with that. Okay, any other questions? These have been really great questions and wonderful responses, Emily. Very much appreciated. And yeah, it's good to think about, a little bit further, as we always do, thinking about our students and how we can help them. And yeah, this is like, for me, it's also a new topic. Like I have not really thought that one of my students may have selective mutism. I may have thought like, oh, maybe they're just shy, or they don't have enough language skills or things like that. But now this is a great topic to understand, what's going on with some students. David says, my oldest patient was mid-70s and a survivor of World War II from Belarus, living in a state mental hospital. Okay, so yeah. Any other questions before we go? We have a few minutes.
Helen, this is Charlotte Bridges. Can
yes.
you guys hear me? I know my camera is not working.
We can hear you.
Sorry. Hi.
Hi.
So I work with our elementary populations. I'm an ESL program specialist and instructional coach. And I just wanted to reiterate, and Emily, I appreciate that you're a practitioner and that you're in it every day. The relationship between the speech therapist and the ESL teacher becomes so important, not only in this case, but because we live in a little bit of the same universe. I had the exact situation almost with two twins, and it was now maybe 10 years ago. And I didn't have the words for what we were doing, but it is what you were showing us. And it's important to remember that the students that when it goes into, I'm not going to say conscious choice, but when it becomes selective mutism, and these children were diagnosed with it and they were language learners, they can still function in many other ways. They play with their friends, they can respond to the teacher in other ways, but that small setting, the ESL room, the speech therapist room, you do have to be conscious and you do have to bring it forward. And it took them till, I know in first grade, they would start whispering little words in a small group to the ESL teacher only when they absolutely felt pressed. And it would be through their lips. You could see the lips, like you can physically see how hard it was for them to get it out. Second grade, we started exactly what you were describing, inviting a buddy to read. And it was their choice. It was a book that they had practiced, that they had read and that they enjoyed. And after a while, with their permission, in second grade, we invited the teacher, who would not pay attention, but just kind of be there and hi, all the children. And it was, again, the attention couldn't be on them. And they made very conscious choices when they started to speak with the teacher in the room. It was, of course, we're watching without letting them know. And it was very clear when it happened. And then after that, that anxiety, the curve that you're showing made so much sense to me, because the anxiety, they were like, wow, nothing happened. You know, it was okay. In third grade, they were speaking. And they're listening during these years. They actually had acquired a lot of language. And so the language came out, but they were definitely diagnosed and they had a lot of support outside of ESL. But I just want to thank you for the presentation, because it gave me a lot of terms that I didn't have then, that, you know, so it was very useful. And again, thank you for connecting with your ESL specialists and working closely with them.
Thank you. I appreciate all of those comments. And yes, it sounds like you were intuitively doing all of the things that we would recommend that you do now. So that's fantastic. And yes, I would just reiterate, support is what these kids need, you know, support from their school teams, consultation between the school teams and the parents, so the parents can carry over what the school team's doing out in the community, and the school team can carry over what the parents are doing. And certainly, like you said, Charlotte, you know, consultation between the professionals that are working with kids, especially for these kids, like we're saying, that, you know, have all of these very different components going on with their development and their language skills. So yes, I think, you know, consulting in a team-based approach is really huge for these kids.
Great. We have about 1 minute. Any other questions, comments before we go? You can unmute yourself if you like, or put something in the chat.
Well, yeah, I want to say something. I love that concept of team-based approach. Just people coming together from different expertise and sharing and become stronger. You know, they say the group is more intelligent than the individual. Also, how about the group is stronger than the individual? So thank you so much for that, and also for just sharing everything. I'm glad that, Emily, you're in there and helping students. It makes it feel good that you're there doing everything you're doing. Thank you.
Thank you. I appreciate that.
Thank you, Emily, so much. Thank you so much. We learned a lot. I feel like I did learn a lot. And thank you, everyone, for your wonderful questions and discussions. And I think it's time to go.
Bye-bye.
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 We look forward to seeing you again for our next presentation, conversations. And also, Mac, do you want to say something about our conference coming up, the Penn TESOL conference, virtual conference coming up?
Yeah, so very quickly, if you go on Penn TESOL East website, you will have all the information. this conference is going to be different. And one of the ways that our keynote speaker is Paul Nation, who is the superstar of teaching vocabulary, reading, and writing. We are very, very excited and honored that Paul Nation is coming. It's a one-time opportunity to listen to a speaker like him. And this time, TESOL East, our friends have really worked hard, and it's going to be a great conference. Please consider attending the conference on November 13. If you want to present and share your work, you can still send your proposals. Everything is there on TESOL East website.
Right. Thank you so much. And if you would like a copy of the slides, please provide your email in the chat. And as soon as Emily gives me, as soon as, Emily said she will make the slides available for everyone who would like to have a copy. All right. Thank you, everyone. And we look forward to seeing you all again. Have a good night, good weekend, and happy and safe Halloween.
All right. Take care.
Good night,
Bye-bye.
everybody. Stay safe.